So what we realized in this complex cancer called lymphoma, that it's difficult to understand and to keep up to date with different subtypes, especially the rarer and smaller subgroups and subtypes. The cutaneous lymphoma, led by Susan Thornton, who we all know dearly, has worked very hard to bring attention to cutaneous lymphomas and to help get patients diagnosed properly in a timely manner. What we realized was that the reach needed to be expanded. And so we've had quite a few talks about this and what does that look like and how can we do it. And with the global reach that we have as a coalition body, we decided to think through what can we do to bring attention to these rare diseases and to touch all the patients around the world. So we started these webinar series with understanding cutaneous lymphoma, so that we can get a real good sense of probably a subtype that most of us don't talk about very much on the day-to-day caring of our patients. So I wanted to introduce Susan. She's going to start us with the She's going to start us off in understanding the patient perspective of cutaneous lymphoma. Susan is the CEO of Cutaneous Lymphoma Foundation, and she's going to, she's also a patient, so she's going to talk to us about what is it like through the patient journey. And then she will introduce Dr. Porcu, who's on the phone as well, and he's on the call from Sydney Kimmel Cancer Center in Philadelphia. So she will introduce him when she's complete and give you a lot more details about him, and then we'll open it up to questions. And as you know, we are taping this, and so it will be available on the website later. So Susan, I'm going to turn it over to you.
Well, good morning, everybody, and thank you. It's really exciting to have all of you joining this morning or this afternoon, depending upon your time zone, and interested in learning about cutaneous lymphoma, which I think most of you know is near and dear to my heart. As Karen mentioned, I am a patient, and I thought I'd put this slide up that gives you a sense of where I have been and am going personally with my journey, just to give you a little context, I guess, from what life looks like with someone diagnosed with cutaneous lymphoma. And my journey is a little bit different, and I think as with anybody in the lymphoma world, you know, everybody's journey is unique to themselves, even for some of the more common B-cell lymphomas. But so just to, again, to give you some context, I was diagnosed in 1991 with stage 1A, which was is the most common subtype of cutaneous lymphoma, a basic rash. And for me, I was very fortunate. It only took me about a year to get diagnosed. But my disease actually progressed, which is a bit rare as well. Only about 10% of people diagnosed with stage 1A mycosis fungoides disease actually progresses, and mine progressed to tumor stage, which was pretty life-threatening in the late 1990s. And I was able to work with experts here in Philadelphia. I was very fortunate to have one of the worldwide experts here in cutaneous lymphomas and be treated mostly with radiation, actually, and interferon, and get the disease under control. And then for the next 10 years, actually have had a little more intensive treatment to keep the disease under control. And really, since 2010, I've been relatively clear of disease, but still in a maintenance role. So I share that with you just to give you the context of, which might be a little bit different than other lymphomas, where for cutaneous lymphomas, most people are in treatment for the rest of their life once they get diagnosed, and it's in various shapes and forms depending upon how the individual's disease manifests. Okay, next slide, Karen. And so for me, I came to the foundation in 2008. I wanted to give back and joined the board, and then joined the organization in 2011 in a formal role. And basically, the premise of the foundation is really to support everyone who's been diagnosed with this disease, helping to educate, to promote awareness, and to really advance patient care, stay in touch with what's going on in the research arena, working collaboratively with all the clinicians worldwide, and of course, supporting and fostering research. And we've done some research grants and so forth. And we do support people worldwide, even though we are located in the U.S. and a lot of our live events are in the U.S., but we've done some live programs in the U.K. over the years, and we're hoping to do a live patient program this fall in Switzerland, and Rosemary and I will work together on that. And we get a lot of inquiries through our website and through email and sometimes phone calls from patients all over asking about the disease, and we do our best to try to support them, provide them with connections to physicians and clinicians around the world, because we're connected with the clinical folks, and then also to help them connect with the local lymphoma organizations, and because we're not on the ground, and you all know your scenarios and your countries much better than we could ever know. So I think we want to do that better, and we want to be able to, which is why one of the reasons for this educational webinar. So go ahead, Karen, next slide. And so just to let you know, we actually have a cutaneous B-cell lymphoma as well, and this lymphoma is the primary organ is the skin, unlike other lymphomas. Next slide, Karen. And so what's different about cutaneous lymphomas? Well, I think one of the biggest differences, it's pretty obvious, it's in the skin, so you can see it, and it's very visible, and it can be quite ugly, frankly, and it can be very traumatic for people living with this. I've spoken to many people who haven't worn short sleeve shirts for decades, or haven't worn shorts, or won't go in a swimming pool because they are ashamed of how their skin looks, and people look at them strange. So we share a lot with other skin diseases, with stigma and emotional issues around that. And then the side effects of the disease, it's intense, it can be intense itching, which I've experienced, and it's worse than any itching you can ever imagine. It's not like poison ivy or a bug bite. It comes from the inside out, and the itching can be so debilitating to people. They can't sleep, they can't function, and so that's another side effect of the impact of the disease. And sometimes just managing the itch is a huge deal, sometimes even more important than dealing with the disease itself. And as I mentioned, it's chronic long-term, and most people are in some form of treatment for life. And the treatments vary from individual, depends on their disease presentation, how their disease reacts to treatments. And it is misdiagnosed most of the time because it looks like other more benign skin conditions like eczema, psoriasis, ringworm, bug bites, any number of things. If you talk to to patients, you'll find that they were diagnosed with all kinds of different skin diseases. And as you'll learn from Dr. Porcu in a little bit, there's some reasons why it's very difficult and challenging to diagnose, and because of the disease itself. So, you know, if you put yourself in the place of a patient who has been going to a dermatologist for several years and being treated for what they think is psoriasis, for example, and it seems to be kind of under control and managed with some topical creams and so forth, and then they decide to do another biopsy, and in perhaps a day, they all of a sudden now have this cancer diagnosis. And one day they had a benign skin condition, and the next day they have this rare cancer. It really messes with people's heads. And their disease may not really have changed. It's just that the diagnosis now has changed. So there's a whole emotional and impact that happens when people get diagnosed, especially if they had been previously diagnosed with a different kind of skin disease. So next slide, Karen. So just, I'm not even going to go through these, but just so you know, for all of us in the lymphoma world, I think we're up to 101 different subtypes. And once you get into the cutaneous lymphomas, there are subtypes under our subtype. So just so you can see here that these are the cutaneous T cells. The two most prevalent are mycosis fungoides and Sézary syndrome. And then we have a group under as well. Next slide, Karen. And next slide, Karen.
Yeah, got it. Just give me a sec.
Sorry. Yeah. And then you'll see we also have cutaneous B-cell lymphomas. So even though most of the lymphomas are B-cell, but we also have cutaneous B-cell lymphomas. So just to let you know that there are different subtypes and that we deal with, and they're treated differently. The cutaneous B cells are treated differently than the cutaneous T cells. Next slide, please. And just to give you some of our words, what we use, because this is a skin lymphoma, we really talk about patches, plaques, tumors, and erythroderma, or redness of the skin, like full body redness. So a patch is something that you can just, you just see it on the skin. A plaque is usually a little bit raised, a little more discolored, and a tumor is something that, you know, a growth, if you will, on the skin. And some people can have all these different combinations all at the same time, or one or the other. So just to give you a sense of what we talk about when we talk about cutaneous lymphomas and the presentation of the disease on the skin. Next slide, please. And then in our world, it's so critical to have a multidisciplinary group that is treating and synergy in care. And Dr. Young Kim from Stanford put this slide together, and I borrowed it from her because I think it really shows nicely that in the best case scenario, you would have a specialist who deals with cutaneous lymphoma as your primary care provider to treat the disease, but there are all of these other folks that play a role. So you can have a cutaneous lymphoma specialist that's a dermatologist, a cutaneous lymphoma specialist who's a hematology oncologist. We have specialty radiation oncologists. There are dermatopathologists and hematopathologists that play a role. So it does take a group, but I will also say that these kind of multidisciplinary specialty practices don't exist in very many places. Even here in the U.S., we don't have at every expert center this wonderful kind of clinical setting. So, patients may typically see a dermatologist, and that can be okay for some folks. And then if people have more progressive disease, a hematology oncologist may come into play. And then I think we need to learn from all of you is how do these different specialty practices work in your country. I know in Europe we're pretty closely aligned with the clinicians worldwide are all connected, the physicians and the researchers, and in a lot of Europe, the primary specialists in cutaneous lymphoma are dermatologists. So, you know, it really depends on the country and getting to know who those experts are and those specialists are. So just maybe a little bit different than a lymphoma who's primarily treated by a hematology oncologist. Next slide, please. And I'm going to turn it over to Dr. Pierluigi Porcu, who is now at the Sidney Kimmel Cancer Center here at Thomas Jefferson in Philadelphia. Dr. Porcu has been engaged with us in the foundation for a long time, and we work very well together. He is currently the co-chair of our newly formed Research Advisory Council. He has been on our board of directors, but he is a specialist in cutaneous oncology, in T-cell lymphomas. He's a hematology oncologist, and he also is engaged in research in cutaneous lymphomas and in T-cell lymphomas in general. So it is really a pleasure to be able to introduce him to you today and to have him take us through a little bit more of the clinical side of the world of cutaneous lymphomas. So I'll turn it over to Dr. Porcu.
Thank you, Susan. Good morning or good afternoon, everyone. I hope you can hear me okay.
Yes.
It's terrific. Thank you. So, Susan, it's a great pleasure to be on the call, and it's really exciting to know that there are so many people around the world that are engaged and active in having advocacy for patients with lymphoma, understanding this incredible complexity of the disease, working together towards finding solutions to it. I'm going to spend just 1 minute explaining why I became interested in CTCL, because I think that this speaks to some of the questions that I have seen coming through from some of you in the audience already through the chatting system about who should be taking care of these patients. Susan, for example, where you were being taken care of initially by a dermatologist and then a radiation oncologist, and this goes to what Susan was saying, that the modality of therapy for cutaneous lymphomas are not necessarily completely different from the modality of therapies for other lymphomas, but they're often used in combination at the same time. Their rotation is significantly faster, and therefore the coordination between all these different doctors is absolutely essential. So, Susan mentioned I am a medical oncologist, which means that I specialize in medical care of patients with cancer. I focus all my life in blood-related cancers, in particular lymphoma. And I was at The Ohio State University in Columbus, Ohio for more than 16 years. And there I developed a strong interest both in terms of research as well as clinical in lymphomas of T cells, so-called T-cell lymphomas. As you may know, T-cell lymphomas are a relatively small minority of cases of lymphoma globally, even though in certain parts of the world the frequency is much higher, and that's one of the things that are interesting to study. For example, in Europe and the U.S., probably T-cell lymphomas represent no more than 12% of all the lymphomas. In some parts of Asia, South America, they represent up to 30 to 35% of all the lymphomas. So there are some geographic differences that are very important. So the research part was really interesting. I found out that essentially to develop the infrastructure to study lymphoma, I really had to focus on all the different forms, which are shown here in this slide that Karen is showing. So the current classification, this is an old slide, but the classification really hasn't, the breakdown hasn't changed. We look at, what we call mature T-cell lymphomas, and clinically, very important, we divide them in 3 or 4 different clinical forms. There are some T-cell lymphomas or T-cell leukemias that have predominantly blood involvement, and you see them on the left of your slide here. And there are some lymphomas that are mostly have, their typical features to present with lymph node involvement, and those resemble the more typical B-cell lymphomas that you may be familiar with, like mantle cell lymphoma, follicular lymphoma, and so on. And then there is a category of T-cell lymphomas that is exclusively extranodal. So in other words, they affect tissues that are not primarily lymph nodes. And then the cutaneous T-cell lymphomas represent a category of their own for all the reasons that Susan has shown. Next slide, Karen, please.
I'm trying. Give me a sec here.
No problem. So as I mentioned, for a researcher or a clinician interested in making a difference in how T-cell lymphoma is develops and how it's treated, it's important to have access and work with all these different types. And this is, Karen, this is an animated slide. I hope it's going to come through okay. If for some reason you have trouble, you let me know and I can stop. This is essentially just to provide a graphic description of, in the context of all the lymphomas, and this is based mostly on numbers here in the U.S., but what is the frequency, what fraction of all those lymphomas is a cutaneous lymphoma? So if you look at all the lymphomas that are being diagnosed, we know that a small fraction of them are called Hodgkin's lymphomas, and then the rest are called non-Hodgkin's lymphoma. This is a kind of a heritage, a long heritage, but it's still applied today. So of all the non-Hodgkin's lymphomas, then, if you keep going, Karen, perfect. We all know, as I mentioned, that most of them are B-cell lymphomas, and there is a smaller fraction of them that are T-cell lymphomas, and there is an even smaller fraction of lymphomas that are non-T-cell, typically NK. And if you keep going, I think we're going to have perfect. Of the T-cell lymphomas, a category is called peripheral T-cell lymphomas, and then cutaneous T-cell lymphomas represent, again, a small subset of all the T-cell lymphomas. There's also a small subset of B-cell lymphomas, as Susan has mentioned, that affect primarily the skin, and they're called cutaneous T-cell lymphomas. So I think there is a couple of more animations, Karen, that you can do it perfect. Yeah. Again, mycosis fungoides and Sézary syndrome, as Susan mentioned, are the majority, the most common, the best described. And then there's a category of cutaneous T-cell lymphomas that are non-mycosis fungoides and non-Sézary. So if we look at all the lymphomas that are being diagnosed, that tiny little fraction right there in the right lower corner of that slide is cutaneous lymphomas. Thank you, Karen. Yeah. So, and this kind of has had the consequence of, the complexity of the care, the multitude of people that have to kind of work together to make a diagnosis and treat it, and the fact that they're so rare really has made advancing science and clinical care in cutaneous lymphoma has slowed it down quite a bit. Now, the good news is that over the past, I would say, past 10 years, there has been a veritable explosion of knowledge in the biology of cutaneous lymphoma, new treatments. Pharmaceutical companies are very interested now in actually exploring and studying cutaneous T-cell lymphoma, often as a way of understanding how their drugs and their compounds affect the neoplastic cancerous T cells. And many of the findings that are then described in cutaneous T-cell lymphoma can often be applied to other T-cell lymphomas as well. So there's really a lot of action right now going on in terms of translational research and drug development. Thank you, Karen. You can move to the next slide. So Susan mentioned some of the words that we use to describe lesions, and I hope the audience is okay looking at some of these slides. There's nothing particularly bad looking in any of the slides I'm showing, but this is a patient with what we call patch and plaque stage mycosis fungoides. The rash affects typically the trunk and the upper thighs, the buttocks. It's called a bathing trunk distribution. And it probably has to do something with the fact that sunlight exposure in many cases actually slows the development of cutaneous T-cell lymphoma. Next slide, please. And these are the more specific definitions of the type of skin lesions. As Susan was mentioning, one of the things about CTCL mycosis fungoides is that it's visible. And you can see in the upper left, the patient has a fairly nondiscrete rash. In those lesions, we call them patch. If the lesion is palpable, you can feel it under your fingers. It's called a plaque. In the left lower panel, you have nodules in the skin. We call them tumors. And then when patients have, the rash affecting more than 80% of their body surface, often with, extensive itching, we call that erythroderma. And each one of those lesions, and depending on the surface involved, go to make our staging system, which is fairly complex and difficult to master, but even for doctors, and that we don't have anything better at this point. But it has served fairly well in terms of discriminating and predicting outcome in patient. Next slide, please. So Susan was mentioning that making the diagnosis of CTCL is difficult, and one of the reasons is that especially in the early stages, clinically the rash could look just about any other rash that you may have had or seen. It could be like a drug reaction, could be looking like psoriasis, eczema, atopic dermatitis. Has very few things that can be specific at any particular snapshot in time. Even when you do a biopsy, often in early stages, it's difficult to make the diagnosis because the number of abnormal cells in the skin are actually small, and there are fewer abnormal cells compared to a lot of inflammatory cells that are infiltrating the skin. One of the reasons is that, even though it's not widely known, this goes back to the issue of why people even develop lymphomas in the skin. The skin is our most important organ of immune surveillance against the environment, or at least is the largest, if not the most important. And therefore, the immune system has, evolution over millennia has designed a system to do immune surveillance in the skin. And therefore, at any given time, if you do a biopsy, even of someone with a normal skin, but even more so with any kind of inflammation of the skin, you're going to find a lot of T cells in the skin. And therefore, in early stages, it's very difficult to know whether the T cells that you're looking at are normal or abnormal. So in the clinic, when we see patients in our multidisciplinary clinic, particularly after they have been going through a lot, several visits with their referring physicians, if we look at the distribution of the rash and the biopsy, the diagnosis can be easier to make. But there are cases, even when patients go to referral centers that have a lot of experience with CTCL. Even in those circumstances, sometimes it's hard for us to know for sure whether patients have CTCL or not. Next slide. Thank you. And what this slide shows essentially is just a graphic description of the things that I was describing. So there are 4 components of making a diagnosis of CTCL from the standpoint of the tissue. The first thing to do is to do a biopsy, which is, taking a specimen from the skin, which is illustrated here by that black square. If we look at the panel on the right that Karen is showing now, you see the skin with the top layer of the skin here being that kind of pink purple layer there, and you see a lot of blue and purple dots in the lower parts of the skin, and that is a T-cell infiltrate. Now, it's not enough to see that to make the diagnosis of cutaneous T-cell lymphoma. You have to have shown in the left lower panel, and I'm sure many of you are familiar with some of these words, you have to have something called immunophenotype, immunostain. So you have to stain the biopsy with a certain number of antibodies that describe what type of cells you're looking at, because just from the morphology, sometimes it's impossible to tell whether those are B cells or T cells and so on. And so CTCL, for the most part, expresses markers called CD3 and CD4. If you look at the CD8 panel right there, which is the center lower of that left lower panel, you see that many fewer cells express CD8, and that is typical. And then you have other markers. Now, the final panel on the right, on the right lower panel there, is something called T-cell receptor gene rearrangement, which is a molecular way of describing, and is also applicable to B cells, but for T cells it's particularly important. This is a molecular way of describing whether or not the T cells in that particular skin biopsy are all belonging to the same family, essentially. They're identical clones of a tumor cell, or they're diverse. And in lymphoma, you would expect a narrow spike showing that there's significant homogeneity of the T cells in the biopsy. That is, by itself is not diagnostic, but in the context of everything else, including the clinical presentation, is very important. Next slide, thank you. So in this cartoon here, if you look at the top bar where it says stage, it tells you sort of, again, it refers graphically to what I was mentioning before. In early stage, which means that patients only have relatively flat, thin rash and localized to a relatively small percentage of the surface. If you look at the cells that are in the skin biopsy, which is the bar just underneath that, then most of the cells are inflammatory cells. We call them CD8. And the neoplastic cells, the lymphoma cells, are CD4. There are fewer of them. And so when you do a biopsy, it's really hard to actually see the abnormal cells. If you go to more advanced stage, as the disease advances, becomes more aggressive, then you have more and more of those CD4 cells. But at that point, though, I think even clinically, probably an expert in CTCL will be able to know just by looking at the patient that you have CTCL. So where really the game changer is going to be finding biomarkers early in the stages where those cells are far and few in the biopsy, and recognizing that those are abnormal cells and making diagnosis. The good news, as I mentioned, is that there are a number of assays, molecular assays, that are being studied right now that I think are going to make the diagnosis of early stage much more efficient and better very, very soon. Next slide. Yeah. Thank you. So I want to spend just a couple of seconds describing staging, something that probably most of you are already familiar with in the context of other types of lymphomas. But essentially, staging is, the purpose in CTCL is just like the purpose in any other lymphoma. It's mapping cancer in the body. How much there is, where is it localized? Next slide, please. And then the purpose is, multiple, predict curability, predict outcome, and so on. Now, there's one important difference between staging in lymphoma in general and a lot of other malignancies. And you know that in most other surgical cancers, the stage is really important to determine curability. If you have stage 1, say lung cancer, very likely that with surgery is curable. If you have stage 3 or 4, it's definitely not curable. This is different from lymphoma, not just CTCL, for lymphoma in general. The stage really is just an indication of the burden of disease and may have some information as to the probability of achieving a certain response or not, but does not predict cure. Cure in lymphoma, as you probably already know, depends on what type of lymphoma you have. If you have diffuse large B-cell lymphoma, that is curable with chemotherapy. If you have mantle cell lymphoma, for example, or CTCL, we know that that is not curable in the sense that even though you have a good remission, the lymphoma tends to come back. Next slide. And this is the staging system for CTCL, which I was mentioning is fairly complicated. The bottom line is that really you have to assess both the skin disease, you have to assess potential involvement of lymph nodes, potential involvement of tissue outside of the lymph nodes, and then the blood system. And then according to which one of those particular components for each compartment you have, we construct this composite staging 1A to 4B with early stage 1A to 2A and advanced stage 2B to 4B. Next slide. And then, as Susan mentioned, general considerations for treatment planning. We often use combination therapies in CTCL. We go from skin-directed therapy to systemic therapy. Often we sequence them according to the stage, according to the needs. And then one of the key fundamental goals of therapy in CTCL is the preservation of immune competence, because we know that if you, for example, immune suppress the patient, especially over a long period of time, the prognosis of CTCL becomes worse. So we tend not to use cytotoxic chemotherapy in these patients, not because cytotoxic chemotherapy is bad per se necessarily. Cytotoxic chemotherapy can be very effective in curable cancers like large B-cell lymphoma, but in CTCL just does not happen to be effective, and therefore we avoid it. Next slide, please. And this is a complex slide, but just to give you a landscape view of all the different types of treatments that are available. And this makes for a fairly complicated decision-making patient by patient, and it gives also a lot of flexibility. So there's no perfect standardized treatment for every single stage of CTCL. It really requires a lot of experience and expertise in individualized assessment of the patient need. And in part, that is because there is no perfect treatment. I think if there was a treatment that was absolutely 100% effective, then this slide will look a lot simpler. But that's not the case. So we have to go with what we have. This is constantly changing. A lot of different therapies now becoming available. And I think the patients benefit from this. Next slide. I'm not going to go through all of this, but the advances affect both skin-directed therapies as well as systemic therapies. Radiation therapy is a very important component of the treatment, again, in combination with all the other treatments. There are some very interesting immune stimulatory therapies now that can be given through the skin. This resiquimod, for example, is in clinical trial. There are some other topical therapies in clinical trial as well. There's always something going on right now in clinical trial development in CTCL. Next slide. And you can click all the animations, Karen. Thank you so much. So as I said, the goals of systemic therapy in CTCL: eliminate malignant cells from the skin and blood, restore or maintain immune competence. We want to prevent the cells from migrating too much out to the skin if possible. And then produce complete responses. I think one of the issues with the treatments we have available so far is that the quality of the responses has not been good. So many patients improve, but the disease is not brought into a complete remission, and that is probably one of the reasons why the disease as defined right now with the treatments we have is not curable. After a certain period of time, the disease always comes back. I think one very important goal in therapy for CTCL is the prevention of stage progression. That's something that we discussed with, Susan, for example, very clearly described her own journey. There are some patients who present with early stage that they do progress and transition from early stage to advanced stage. And I think that we haven't really been able to focus too much on what to do to prevent that transition. And I think that's going to be one of the most important goals for therapy over the next several years. We want to, of course, improve survival and always, no matter what, try to improve patient quality of life. Next slide, please. There are a number of drugs that are available for the treatment of CTCL, and most recently 4 therapies were developed. They are listed in the slide right there. Romidepsin, vorinostat, bexarotene, and most recently brentuximab. So again, the good news is that there's a lot of new drugs being developed, many more under development right now. And I think that we're learning how to attack the lymphoma cells better every year. So I'm optimistic about the future. I believe that's my last slide. Thank you so much, Karen. I don't see anything else here on the screen.
I think you have one more piece.
I do. You know what? I tell you why I don't see anything, because my computer locked me out.
You can probably go to the last slide, Karen. I think we just talked a little bit about this. Just go to the next one. There we go. It's just let's see here. Above that one. Sorry, Karen, you went one too far. There you go.
Oh yeah. Okay, I got it now. Perfect. So again, discussing the progress just over the past few years, there was a very large randomized clinical trial. Now, finally, we have been able to complete randomized clinical trials in CTCL. Something's been very difficult to do. The name of this clinical trial was Alcanza. That's the one that led to the approval of brentuximab, which targets CD30, a drug that is used for many other lymphomas beyond CTCL, including Hodgkin's lymphoma. Another clinical trial called Maverick was just completed and is currently being presented and published. That is leading to the development of a drug called mogamulizumab, which we hope is going to be approved soon. There's an international collaboration that led by Dr. Yan Kim that Susan mentioned at the beginning of her talk, as well as Julia Scarisbrick from the UK. Essentially, we're describing the landscape of the natural history of cutaneous T-cell lymphoma globally. Those are very important projects. They're not necessarily treatment, but they describe the disease. And then there's a host of new drugs being developed, many of them in the immunotherapy field. Next slide.
I think that's it.
Perfect. Yeah. Thank you so much. So I hope that we went through very quickly, but I'm happy to with Susan to take any questions, and hopefully we can discuss that further. Thank you, everyone, for listening. Appreciate it.
Thank you, Dr. Porcu. That was really well done, and we really appreciate it. It was a really good overview, and I think all of us really now can understand how complex this disease is and how much there is to know. Some of the important things to know for patients is a question that Giora put forward as well that I had for you, for both of you, and that is the diagnosis journey. Giora asked in the chat room about diagnoses of through the dermatologist or through the hematologist, and how do you get from a dermatologist to a hematologist, and what are those issues, both that we should sort of guide our patients on when we're having chats on the phone when it comes to that issue?
Karen, Susan, you want to take that?
Sure. So I think one of the key elements really is the clinician needs to be a specialist in the field, or at least have some knowledge of cutaneous lymphomas. And again, it could be that it's a dermatologist because they have an expertise in cutaneous lymphoma, or it could be a hematology oncologist. I think, as I mentioned, the experts in the field in Europe tend to be more on the dermatologist side than the hematology oncologist. I think it's important for patients, if they're seeing a local dermatologist, that's probably how they'll come through to get a diagnosis. If they have a diagnosis, would be through the dermatologist, because it shows up in the skin, and that's the first place after a GP that someone would be sent. So I think the key is knowing who the experts in the field are in your country, and to try to refer people, or even refer the local physicians to the expert physicians, because sometimes distance is an issue. And we have that problem here in the U.S. as well. There are not experts in cutaneous lymphoma at even all the major cancer centers here in the U.S. So people may have to travel to see an expert in the field. And if that's not possible, I usually recommend that they have their physician, whether it's a dermatologist or a hematology oncologist, contact one of the experts in the field, so they can at least converse and help, perhaps consult on care and treatment and so forth. Dr. Porcu, do you have any other thoughts on that?
No, I agree. That's very important what you said. I think that the one thing to understand is that, and I don't think we have mapped that out very well or completely for the public, actually, and for patients. But we have to understand what are the critical milestones in the journey of a patient who is diagnosed with CTCL. And one of the watershed moments, I think, is the decision that systemic therapy is necessary. And that is not an easy decision to make. Even experts, to some degree, are not completely on the same page on that. But once the decision to start systemic therapy is made, that's where it becomes absolutely essential what kind of healthcare model you live in. Because in the U.S., dermatologists do not administer systemic therapies, the vast majority of them. With some exceptions in large cancer centers, but certainly in the community, dermatologists as a whole they don't have the infrastructure, they don't have the resources, they don't have the nursing necessary to do that, or the pharmacy necessary to do that. So in the U.S., that's when the transition from dermatology to hematology or medical oncology is essential. In Europe, as Susan pointed out, it is different. In Europe, the dermatologists are organized in a better way, if you want to say that, or a different way, and they're able to actually maintain and continue to give some of those systemic therapies as well. So the important thing is, there has to be communication and dialogue between the dermatologist and the hematologist. And ideally, these decisions about transitioning the practice and the modality of care, it's a decision that should be made openly in the context of a dialogue, and not just when the patient, for example, progresses, then is referred to a hematologist, and then the patient is not seen by the dermatologist anymore. There's a lot of sort of silos that in the past had been developed. And people were not, the natural history of the disease was not well understood, even on the physician side. And I think that we made a lot of progress in that, but we still have to go.
Sorry, I would just add to that, because this is skin lymphoma, there's always going to be a skin component. So I think it's also important, if possible, again, to have that joint kind of expertise, especially if people have more advanced disease, because the skin then becomes it's very important to be able to care for and treat the skin, and in addition to treating the disease. So there's skin care, and there could be wound care and all of that in addition to. So a little more complex.
Great. Thank you for that. Are there any questions from our participants?
We've just fried everybody's brain too much.
Right. Oh, we have one here. Go ahead.
Hi, Susan. I have a question for you. It's Karen Royds from Lymphoma Coalition, and thank you for taking the time to educate us on cutaneous lymphoma. My question is, when you were first diagnosed in the early 90s, what was the landscape of cutaneous lymphoma nonprofit organizations like? Were there patient organizations out there to help you, and how has that changed now, since there's just been so much more research and discoveries of the disease itself?
Yeah, so when I was first diagnosed in the early 90s, there was no internet, so that tells you something. There was no, I basically received I was handed a medical scientific paper that explained the disease, and that was pretty much all I got. And actually, even back in the early 90s, there was no Leukemia and Lymphoma Society. There was no Lymphoma Research Foundation. So I think we've come a long way in the establishment of patient organizations that specialize and really can help people navigate and deal with a lot of the emotional issues and the other kinds of things that come along as part of the disease. So we were established in 1998 officially, and I didn't really even know about the foundation until probably the mid-2000s. So, for me, I did a lot of research on my own. And today I think we've kind of gone the opposite, that if, everybody can go in and go to Dr. Google, right? And you get all of this information, but you have no idea what applies to you and what's appropriate to you. And I think that's our role now as far as patient organizations go, is to really help people understand what's applicable to them. And particularly in cutaneous lymphomas, because if you Google, and people do it all the time, even though they're told not to, it brings up all the really scary pictures and all of the really scary prognosis factors. And most of the people that are diagnosed with cutaneous lymphoma have early stage mycosis fungoides, which may never, ever progress, and they have a normal life expectancy. So it can really freak people out, and it isn't applicable. So I think now our role is how do we, one of our challenges continues to be to create awareness that we actually exist, and to work closely with the providers in the field so that they refer to us, so that we can, help support and navigate folks and their families when they have all those other questions that are maybe not clinical in nature. And so I think, the awareness factor and that we are really there to help support and provide additional that navigation. I don't know if that actually answered your question, but.
No, it did. Thank you.
Yeah.
Thank you. And Susan, just to add to what you said, your story's online somewhere, isn't it?
I think we have a printed story. I'm not sure if the total thing, but there's a lot out there on our website. I don't know where it is exactly.
Okay. All right. So if there aren't any other questions, we can move on to your last slide, Susan.
Yep, sure. And we're almost right on time, so that's pretty good.
Nice job.
So I want to actually share my appreciation for everyone who joined and was interested in learning more about cutaneous lymphomas. And I would encourage you to, head out to our website. We have tons of information out there. We also list the treatment centers worldwide. One of our big projects is to update that and refresh that for the world, so that people, if they find us or, you know, through a Google search and they're not in the U.S. or they are in the U.S. or they're outside of the U.S., that they can actually get information. And we do have the Google Translate on our website, so hopefully people can get information in their language. But I think, you know, the key is we're happy to help. We have a lot of information and no need. I think one of the keys is we're happy to share it with you, so you don't have to reinvent the wheel. I think this is a you know, kind of a unique subtype of disease. So with 101 different lymphomas, how are you supposed to know all the ins and outs of every individual lymphoma? So let us help you, and happy to collaborate in any way. I know we've done some collaborations with the folks in the UK and with Rosemary in Switzerland, and we're happy to provide you with you know, any of our information that would be of service, and to figure out ways to collaborate so that we can support patients no matter where they live. So I think that's it.
All right. So there are some resources for you. The Cutaneous Lymphoma Foundation has resources. I think a couple of countries like Rosemary is taking the materials and translating them so you don't have to duplicate effort. The Cutaneous Lymphoma report is on the Lymphoma Coalition website. You can use that as a way to have a better understanding. Natasha, you put a question forward around side effects and risk factors for treatment, and maybe that's something we can talk to at a different time. But I just want to say thank you to Dr. Porcu and to Susan for making time today to help us better understand all of it. And thank you to all of you for joining, and as Susan said, to better understand this really rare disease that we're all trying to wrap our head around right now, called cutaneous lymphomas. So thank you, and have a good afternoon, a good evening, or a good morning.
Thank you very much.
Thank you, Karen.
Thank you.
Yeah. Thank you, everybody.
Thank you.
Bye.
Thanks. Bye. Bye.
Oh, Monica.